important in the context of what we are going to talk about today. The ability to, for example, Dipanjan was asking me that how do you differentiate between a central pulmonary mass and surrounding atelectasis? Because they could both look similar when you're planning for radiation. So what are the techniques that you can use? So I'll talk about the conventional techniques, but this is a technique that is something that is going to come and you're going to use these things in the near future. So the concept of dual energy CT is that, so let's look at two concepts. One is a mono-energetic and one is a multi-energetic CT. What does a mono-energetic CT mean? So in radiation also, in radiotherapy also, you know that when a beam, X-ray beam comes in, there is a KEV. The KEV determines how penetrative the beam is. So as the beam is penetrating the body, if the KEV is higher, it penetrates more, right? So if the beam is, if the KEV is higher, the beam penetrates, right? So what do? In a mono-energetic CT, we have 80 kV or 120 kV. Depending upon how fat the patient is, we decide on which protocol are we doing, how density is the contrast that we need to penetrate the iodine. We determine the kV. So it is a single bar, 80, 120. Now, if you have got two energy sources, so let's say one is 80 and one is a 120. Now, as you know, every energy source is a bar, is a bell curve, right? So your 80 is a bell curve like this, your 120 is a bell curve like this. So then you actually have got energy data for the whole spectrum. You can then retrospectively reconstruct this at 40 keV or at 160 keV. For example, if you have got a very low contrast situation where, let's say you've got a very delayed phase scan and you want to see the pulmonary artery margins, if you reconstruct the image at 40 keV, of course, you're going to see the pulmonary artery brighter. So it will become like an angiogram. On the other hand, if you've got a metal artifact, if you've got a streak artifact from the brachiocephalic vein when you're using contrast, if you've got that, and the streak artifact is obscuring part of your tumor identification, you can increase the KEV from that same set of data to 160 to reduce the metal artifact or the streak artifact. You can reduce it. So basically, from the same set of data, you can manipulate it to give what you want. So this is the advantage of dual energy CT. So this is the advantage of dual energy CT. So the standard way that we do in Siemens here is there are two energy tubes. The way Philips does it is that there are two detectors, okay? So one is called a sandwich detector. So it attenuates to different degree so that then you get a spectrum. What GE does is it's got two focal spots and it switches very quickly. Automatic switching of the focal spots. So there is various ways of doing dual energy, but dual energy CT is going to be very important in the next few years. And the principle I explained to you, because what you can also do is you can do a material decomposition. You can actually look at iodine content and you can do material decomposition. Not only can you differentiate between fat and soft tissue, you can differentiate between tumor and soft tissue and between various types of tumor. And we believe in between a treated tumor and an untreated tumor. So this is going to become very, very important. So with that, I'm just going to start talking to you about normal anatomy. Let me just start with the normal lung anatomy. So as you know, these are lung windows, minus 500, 1500 window level and window width. So basically to identify the lung, you're looking for an obvious mass, but normally the lung is an air-filled structure interspersed with, so here is a nodule, you can see a little nodule here, interspersed with vessels and bronchi, right? So general principles are the trachea divides into right and left brain bronchus. And then the key aspect that you need to learn is the bronchial anatomy in terms of what are the lobes and what are the bronchi. So one of the easy ways of following the lobes is to follow the bronchi. Of course, the right side, the right upper lobe bronchus first, then the main interlobar bronchus, which first gives off the apical lower lobe bronchus, which goes to the back, and the right middle lobe bronchus that comes to the front, and then 4 basal bronchi, right? So that is on the right side, and similarly on the left side, three basal bronchi, but it goes along similar lines. The other thing that you need to be aware of is the fissure, and this is the oblique fissure. You can see typically the white line has a little bit of dark area next to it, so it is easy to identify the fissure. And of course, then you have the horizontal fissure differentiating the right middle lobe from the right lower lobe. So that is regarding the lung parenchymal anatomy. I'm not going to talk today about HRCT anatomy. Of course, if you have a mass, then you can talk about the margins of the mass, whether it is spiculated, the size of the mass, whether it's got calcium, whether it's heterogeneous, homogeneous, all of that. I'm not going to talk about that. Then when it comes to, I've intentionally put a non-contrast image because sometimes I guess you will have to plan based on a non-contrast image. So the central mediastinal structures, just before you go to the central mediastinum, just remember that the subclavian arteries and veins are visible, the axillary nodes are visible, the anterior chest wall muscles are visible, and of course, so are the posterior chest wall muscle and both shoulder joints. So as you enter the mediastinum, this is the left brachiocephalic trunk. These are the three great vessels, the brachiocephalic artery, the left common carotid. Hey, boss. Please. And this is the left subclavian artery. This is the brachiocephalic vein joining the SBC, right? Watch there. And then the SBC comes down to the right atrium. So, and then this is the ascending aorta, descending aorta, pulmonary trunk. You know these things, right? Main pulmonary artery, right and left main pulmonary artery. And then the pulmonary artery, they divide as do the bronchi. And then you have the cardiac structures. So you can see that there is considerable coronary artery calcification in this patient. And the cardiac structures would include things like this is the left atrial appendage, commonest place for thrombi, clot being accumulated. And then, of course, the left atrium, the right atrium. And then as you come down further down, the right ventricle in this half and the left ventricle in this half, that is not shown here. So that is the standard mediastinal anatomy. Again, this is post-contrast mediastinal anatomy just to make things a little bit easier. And just since we have got some small nodes, let us talk about these nodes. So these are what I would call prevascular nodes. These are the pretracheal nodes. They can be upper pretracheal, lower pretracheal, tracheal, or precarinal nodes. We will talk about the numbered system in a second. Then these nodes here in the middle between the aorta and the pulmonary artery. Sorry, I should stop it. Just slightly above this. Those are the aortopulmonary nodes. And then, of course, you have the subcarinal node. Then you have the hilar nodes, the superior hilar nodes. Only hilar nodes usually means the middle hilar nodes and then the inferior hilar nodes. And similarly, this, which is basically 4R, 4L, and which is again similarly on the left side. So, but the vascular anatomy, as you can see, pulmonary artery, aorta, descending aorta, SVC, right atrium, left atrium, right ventricle, left ventricle. Okay. Okay. Right. Coronary sinus, IVC here. That's more or less it. Okay. And sorry. And if you really want the internal mammary artery and vein, and of course the intercostal arteries and vein, and the spinal cord and its structures. So normal lung anatomy, we've already done it. So one of the things that I commonly use if I want to identify a nodule is we do a MIP in the coronal plane. MIP means you thicken the slices, and we MIP in the coronal plane because it just makes nodules become a little bit more obvious. And we do that quite routinely. We've talked about the major fissures already. So in the setting of the lung tumor, it is really important because it can sometimes cross the fissure, and that has got implications in terms of both staging and in terms of treatment planning. We have already done this. Of course, the density is, as you can see, more in the pulmonary artery. Now, this is about the phase and the physicity of your acquisition. Always remember that a standard pulmonary angiogram or a pulmonary arterial study is different to a bronchial arterial study, because the pulmonary artery contrast comes before the contrast gets to the aorta. So these are two different studies. If you do it a little bit late, you will get contrast in both places. But if you want a truly pulmonary angiographic study, you need to hit the play button a little bit sooner. So that brings me a little bit to lung cancer staging. And as you can see that, you know this, less than T0, and then T1 is tumor less than 3 centimeter, which can be subdivided into A, B, C. T2 is between 3 and 5 centimeter. T3 is more than 5, but less than 7, and T4 is more than 7. But there are several other characteristics. For example, T3 is with distal obstructive atelectasis. T3 is with visceral pleural involvement. T4 is with parietal pleural involvement. There is the question about a satellite nodule. If it is in the same lobe, it is T3. If it is in the same lung, then it is T4. If it is on the contralateral lung, then it is M1 disease. In other words, anything that can be dealt with by removing by a pneumonectomy can be considered to be T4. So similarly, when we come to nodes, the nodes are N0, N1, N2, N3, ipsilateral pulmonary nodes, ipsilateral mediastinal nodes, which means the pretracheal, paratracheal, subcarinal nodes, and then contralateral mediastinal nodes or supraclavicular nodes are N3 nodes. And then within this, you can have you can have subdivision of nodes as well. And then you can bunch these T and N stages into stages: stage 0, stage 1, stage 2, stage 3. I think you guys know this. I'm not going to go through this in details, because let me just take the next 10 minutes talking about the anatomy that is relevant to the staging. So we know that, the nodal stations, we should ideally describe them. We are still old-fashioned, and we still describe them as we were taught anatomically. But of course, you can have a level 1 is, nodal station number 1, 2, 3, 4. Level 4 is lower paratracheal, including the azygous nodes. And then, and then the inferior mediastinal nodes, which are the subcarinal, the paraesophageal, or the inferior hilar, or the pulmonary ligament nodes. And then you have the N1 nodes, which are the hilar nodes. So, 10R, 10L, etc. The interlobar nodes. And as you go down the bronchus, further down segmentally into the bronchus, you can go 10, 11, 12, 13, 14. Right. So this is a case of, as you can see, multiple pleural-based masses. I actually can't remember what it was histologically now. It has been I'm opening this presentation after a long time, but let's just look at this as if we are looking at it for the first time. So here we have a contrast enhanced, quite an arterial phase contrast enhanced CT scan, in which there is what looks like a primary mass lesion. Looks like a primary mass lesion in the inferior part of the right hilum, right? As you can see here, which medially extends to within 2 centimeters of the carina. Perhaps we'll have a look at the abdominal windows if I have. And then there is an element of obstructive atelectasis. Now, even in the lung windows, can you make the difference? If you change the windows, you will be able to make the difference between potential obstructive atelectasis and the tumor in terms of the density. If you change the windows, you will usually be able to make the difference. We'll show you. This is this is slightly wider windows. You need to make the windows slightly shallower to see this very well. But now we also have a lot of pleural-based lesions on the other side, which are, if it is a lung cancer, then these are potentially multiple contralateral pleural-based metastases. Then we can talk about the lymph nodes. So clearly we have got some superior hilar lymph nodes. Again, the windowing is not right. Now, if you look at this particular set of nodes, these are prevascular nodes. Superior mediastinal lymph nodes, is probably nodal station 3 lymph nodes. So these are oval with a central fat density, and these are probably benign nodes and not involved. But the superior hilar node here, or potentially the subcarinal node here, is almost certainly involved. So we need to talk about abutment of the left atrium, about involvement of the pericardium. Left atrium is very seldom involved by lung tumor. So oftentimes it is abutted rather than involved. But in this case, we do need to look at seriously whether there is a possibility of pericardial involvement or not. So, so just coming to another case here.
Sorry to interrupt you for once. So we have 5 minutes left for this.
So let us just have a look at this. Okay, so here is a much smaller mass measuring around 4 centimeter, very close to the right hilum, involving up to the hilum, but not within 2 centimeters of the carina. So this is probably a T3, depending upon whether it is more than 5 centimeters or not. And then there is not significant obstructive atelectasis. This is limited to the right lower lobe. There are some small nodules. We'll have a look at that in the lung windows. And then just having we'll have a quick look at the lungs, right? So here we can see that it bulges the fissure. See, it bulges the fissure. If it crosses the fissure, then it is difficult in terms of, it upstages itself, because then it becomes a T4, because the patient will have to be dealt only by pneumonectomy. But sometimes you will have a bulging of the fissure rather than true involvement of the fissure. So this, I think, is a more of a bulge rather than true involvement of the fissure. Now, there are some distal, as you can see, some satellite nodules in the same lobe. So these are therefore T3. And we talked about, let's just have a look whether the subcarinal node is involved or not. So in terms of radiation planning, so in this particular case, I think doing a boundary to this tumor is pretty easy, right? For you guys, the tumor is quite well seen. It is quite well defined. The boundary is quite clear. And there is no immediately subjacent obstructive atelectasis that is adherent to the mass itself. And the subcarinal node also is, and there is also a significantly enlarged precarinal node too. So these have got central, this is N2 disease, multiple central mediastinal N2B disease. So, so this one provisionally I would stage it as a T3 N2B, having not looked at it so very well. And then we'll of course have a look at the lung windows. And Dipanjan, can I just quickly ask you, is there anything more you wanted me to talk about in terms of radiation planning for this? I have another case to quickly show.
Yes, sir. Please
of course, we also have got access to PET, and we can see that both of those two nodes and this particular pulmonary mass is hot. And of course, PET would be another very good way of distinguishing between what is the tumor margin and what is the obstructive atelectasis. However, of course, I know that you don't get access to PET at the time of planning, because you have to do the planning on CT. So I will show you some more tricks in a second. So of course, if you're going to get dual energy CT, it is going to be a game changer, because you can actually do a PET like iodine density map, and you can differentiate between the structures. So this one, on the other hand, I just wanted to show this a bit later. This one, on the other hand, is a little bit more difficult. Is it? Yeah. So here you have a peripheral mass, as you can see, quite a large 8.5 centimeter peripheral mass abutting the pleura. We need to understand whether the visceral parietal pleura is involved, whether there's any chest wall invasion, because that would of course upstage it. It of course is abutting the fissure, but doesn't bulge it so much. But here it looks like a homogeneous soft tissue mass, right? Now, if you look at it on the post contrast images, can I convince you? I don't have 1 second. I'll see if I can get mine. Can I convince you that if I window properly, there is a difference between this slightly nodular enhancing margin of the tumor to a little bit of compressed atelectasis? Now, I'm sure when you do the planning, this much of compressed atelectasis is you're not going to bother saving this. But suppose if it was larger, these are patients that I dug out yesterday when Dipanjan reminded me. So I could have shown you better examples, but I think I can convince you that you can still make the difference between the tumor and the distal very small amount of obstructive atelectasis. Now, in this case, the tumor is more hypervascular than the background obstructive atelectasis. However, and you can actually see it on the PET too. You can see the not avid little triangle of lung tissue, compressed lung tissue, which you cannot appreciate on the lung windows, of course. Now, in this case, what I wanted to share is that this is more hypervascular than the background lung, but usually the situation is completely different. Now, this is MRI chest, but in the setting of post-contrast enhancement, usually a typical non-small cell lung cancer is less enhancing than the distal obstructive atelectasis. This is usually the case, and this is diffusion weighted imaging corresponding to this area of tumor, and this is the PET, and this is the area which is obstructive atelectasis. So I think today what I wanted to quickly talk to you about was what is normal mediastinal anatomy, what are the normal structures that we look at, few tips and pointers towards how to differentiate between tumor and compressed atelectasis, and of course just a semblance of an idea of what the future is in terms of radiation planning, in terms of co-registration with PET-CT, co-registration with MRI, or co-registration with dual energy CT. Thank you very much indeed.
Thank you so much, sir, for that elaborative talk. I would like to call upon our for today, Dr. Naveen Mumudi, sir, an associate professor in the radiation department.
Hello.
In Mumbai. So Naveen Mumudi, sir, is currently driving right now. So couldn't be.
I'm so sorry. My voice was muted. Sorry, did I miss anything?
Sorry, sir. I mean, thank you so much for that elaborative talk.
Okay.
We are moving on to our next speaker for today. So Naveen Mumudi, sir, couldn't be present over here today live session. He has sent us his recorded session. But he's still present over here to take up any questions that you have over the session. So without further ado, I would ask Dr. Dipanjan, sir, to start the recorded session by Dr. Naveen.
West Bengal of Contouring and Radiotherapy Planning 2022 course. And I would like to thank the organizers for inviting me to talk on lung malignancy. I hope you're able to see my screen and you're able to hear me loud and clear. So my topic today is going to be on radiotherapy planning nuances. And this is the outline of my talk with the basics of immobilization, very little about motion management because we already have a speaker talking about it. And then I will move on to how do we contour the primary disease in lung cancer, and I'll also talk about how to contour the nodal disease. And once you're done with contouring GTV, we'll see how to generate CTV from the GTV and also how to go about the PTV generation. And then we will talk about planning proper, in which I will talk about 2D and 3D briefly and talk more about IMRT VMAT planning because that is what is recommended that we do for patients with lung cancer when you're treating them radically. And then I will end the talk by how we evaluate the various planning criteria that we use to evaluate a robust plan. So to begin with, what are the challenges in lung cancer? Why is lung cancer planning and treatment so unique? This is because there's a lot of challenges right from the process of delineation and target definition, and add to that fact that the organ motion, which is very unique in lung cancer, adds a different dimension of complexity. And then you also have a difficulty in ascertaining what is the ideal microscopic disease, the subclinical extent that you need to add to your GTV to generate your CTV. And more importantly, the most unique thing about lung cancer is the tissue heterogeneity that you come across when you're going to do the radiation planning. So we will see about all this briefly later. This tissue heterogeneity leads to certain uncertainty while you are doing the dose calculation. And also, last but not the least, that there's a lot of interfraction and also intrafraction changes. So when we, so this is the workflow in any lung cancer radiotherapy planning, and we will see where are the challenges and how we go about it. So as I mentioned earlier, the lung moves with respiration, and because the tumor is within the lung parenchyma, it moves along with respiration. And the problem with the tumor motion is that not only does it move up and down with expression, but the path that it takes during inspiration and expiration are completely different. So these are things which you need to keep in mind. Within patient, it has also been seen that not only the primary moves, but also the lymph nodes, which could be in the hilum or in the mediastinal region, they can also move with respiration. And this change, this movement actually might not be constant throughout the course of treatment. It might change during the various phases because the tumor might increase or decrease during treatment, which itself lends it to a certain amount of dynamics. So these are things which you need to remember while you're doing your radiotherapy contouring and planning. So all this respiratory motion, what it does is that it also causes artifacts when you're doing the image acquisition for contouring purpose, and it also limits you during treatment planning, and there are certain limitations which you need to also understand while you're delivering the treatment as such. So coming to immobilization, which is the first step in our radiotherapy planning, what we need to make sure is that we place the patient comfortably and we are able to accurately reposition the patient when the patient comes back for the subsequent treatment. So during your simulation, you need to make sure that you're minimizing voluntary and involuntary motion of the patient. There are various ways which we can do immobilization. Various institutions have their own different setups. What we use in our setup earlier, what we used to do was just use a slanting breastboard or just an armrest, but later we realized that it's not enough. So what we started doing now is we use the all-in-one thoracic board where you basically have some amenities so that the patient can keep their hands above their head and in a reproducible fashion. You could also use a vac lock, or you could use a thermoplastic mask. The thermoplastic mask we generally use for patients in whom we need to treat the neck because you need to, there's a shoulder. So these are patients who have supraclavicular approach. And we use vac lock generally for patients who require stereotactic radiation. So SBRT lung patients would have a vac lock for these patients. So as I said, we need to make sure that whatever immobilization device that we're using is comfortable for the patient because your treatment process is anywhere between 15 to 20 minutes and we don't want the patient to move and we don't want any geographical misses. And when you're using your immobilization device, you have to be extremely careful because these devices sometimes can interfere with the imaging that you're going to do on board, and that should not cause any artifact because then you will not be able to match properly. And some of the positions you have to be careful again because you don't want hands on the shoulder to come in between the treatment beam. So you can use different kind of immobilization devices. You can use a vac lock for your SBRT treatment, or you could use just a thermoplastic mask or any other device that is available that you can shoot as long as you're able to fulfill most of this criteria. The other thing that you need to remember is that many of these patients are old and they might be anxious about the entire radiotherapy process. So it's better that you counsel these patients. Sometimes when patients have pain, it is also better that you prescribe them analgesics. This is true because many of these patients might be having periarthritis, so they might have difficulty in abducting their shoulder for too long. So there is no harm in prescribing them any analgesics or anxiolytics for that matter if you have a very anxious patient. So once you have immobilized the patient, then you need to also concentrate on what kind of a motion management you're going to use. I'm not going to go too deep into this because Dr. Moses is going to talk to you about this. You could use either an abdominal compression plate, or use a pressure belt, or you could use any other form of motion mitigation strategy that your institute has. But what is more important is that you would like to keep this, you would like to scan these patients in a position which You could co-register your other images. For example, some patients might have had a PET CT scan, or some patients might even have an MRI done. So if you're going to co-register those images with your planning CT scan, you need to make sure that you are having a similar position as much as possible. So once you have done your immobilization, the CT scan that you will do, this is what we do at our institution, and this is pretty much standard. So you could have any thickness of between 2 to 3 millimeter if you're doing an SBRT treatment. But if you're using patients who are for conventional fractionation, then possibly you could do even a 5 millimeter CT cut. But again, I would recommend doing at least a 3 millimeter CT slice thickness as much as possible, because this allows you to generate high resolution DRRs later, which you could use for your online matching. And also it obviously helps you delineate the tumor better. But you make sure that whenever you're doing your CT scan, you're covering the entire lung. So what we typically do is we start from the required cartilage till the second lumbar vertebra. So this is a standard field of view that we image in our planning CT scan. But this not necessarily need not limit yourself to this. But if you have a patient who requires the supraclavian node to be treated, then you might go further up. Or if you have a lower lobe tumor, you might even go further below this second lumbar vertebra, because you will want to contact the liver and possibly the spleen also. We do prescribe intravenous contrast for all our patients, because this would help you to delineate not just the mediastinal lymph nodes, but also sometimes when you have centrally located primary tumors, it becomes extremely hard to differentiate between where your primary is and which is your grade. So giving IV contrast helps these patients, helps in these situations. So this is just to demonstrate how imaging artifacts would appear if you don't take into account any motion management strategy. Because as you can see, during respiration, the tumor moves, and this leads to a lot of artifacts, and this would lead to a lot of uncertainty during the contouring. So there are various methods in which you could do the motion management, and you could choose, as I said, depending on what amenities you have at your institution. But the commonest thing that is done is doing a 4D CT scan, although you have certain other alternatives for doing this, but the most recommended one is to do a 4D CT scan. What a 4D CT scan does is that in your conventional CT, you would see that this is the tumor, because this is a snapshot of the entire excursion of the tumor within the lung. But by doing the 4D CT, you're able to capture the entire excursion and not just one phase of the excursion. So the tumor might appear longer. This is because the 4D CT gives you the maximum, this basically the maximum intensity projection view. So you can make sure that you're covering the tumor in all its course during inspiration. So it might seem a little large, but that is the sure way of making sure that you're covering the tumor in its entirety. So I would skip this. There are various ways, once you've done the 4D CT scan, how to draw this CTV, what you're drawing the writing. So what you're basically drawing here is not just your GTV, but you're drawing the ITV, because you're including your internal target motion along with the GTV. So what we call it in our institution is the IGTV. So it's not your internal margin added to the CTV, but rather you're adding that internal margin to the GTV. So we call it IGTV. So what we do here is that once you have the 4D CT, you have a couple of ways in going about your contouring. So one way is to just contour on all the faces, because as you know, the 4D CT gives you 10 different faces, contour on all faces, and then you submit. Or the other way of doing it is just looking at the MIP and you contour on the MIP, and then you run it through the cine mode and see that during all the faces you have covered your tumors. Or you could, in fact, if you are in a busy setup, you need to contour a lot of patients, you might not have the time to contour each faces, but you could select few faces and then contour. So the most commonly selected faces are the end expiration, mid expiration, end inspiration, and the mid inspiration. That's at least 4 faces if you take, that has been shown to be as good as taking a 10 phase 4D CT contour. So this is just to show you. So we have drawn this patient's contour on a uh, MIP, and this is the envelope that you're seeing, the IGTV, and as you can see during different phases, so these are the different phases, you're fairly sure the tumor is contained within this envelope. But again, this is one of the pitfalls of using ITV generation with MIP, because when the tumor is close to the mediastinum or close to the diaphragm, it becomes extremely hard to differentiate again between the tumor and the other structures. So we generally don't do this in patients who have tumors close to the diaphragm. Rather, I would do some sort of deep inspiratory breath hold if the patient is able to hold it. The other ways of doing the contouring is also by using the average intensity projection. It gives you conservative volumes, but what happens with AIP as compared to the MIP is that the borders are slightly blurred, and also it is not as comprehensive as your MIP. So you might be underdosing the tumor in some part, some phases of this. So this is just a quick comparison for the contouring part, how you do it. So if you look at it, the ITV, either by using the MIP or the average intensity projection, is the best way to do it. You also have something called the mid-ventilation CT or the mid-position CT, which are basically time-weighted CT scans, which have added workload because you need to do a lot of other co-registration or deformable registration with this, but the reliability of the dose calculation is much better with these. But by using a simple ITV based contouring is the most useful way to do this. So while contouring, it is also very important to note the kind of window that you're using for your contouring. So if you just simply look at your mediastinal window, you might be missing much of your tumor. So it is always better to check both the mediastinal window and the lung window. Typically, we use the mediastinal window to initially delineate the primary and also the lymph nodes, and then cross-check the primary delineation on the lung window. So these are the different window levels that you need to remember. Most of these are already presets in your workstation, but it's also good to know these different values. So this again to demonstrate how the window level actually helps you to completely delineate the tumor, because you might be missing some part of the tumor which may not be as visible as it is in the lung window. Right. So I mentioned briefly about the co-registration. What we typically do is use either a PET-CT or an MRI. PET-CT is more commonly used. The advantage of doing a PET-CT is that this serves both as a diagnostic and also it helps you in the radiotherapy planning. It impacts on the nodal staging, because many times in endemic areas of tuberculosis, it kind of becomes difficult to differentiate between infective and inflammatory or diseased lymph node. PET-CT to a certain extent would help you. And also many times there might be a lot of inter-observer variation in contouring. So PET-CT kind of negates to a certain extent. But there are certain challenges with PET-CT based planning. What you need to remember is that there is a limited spatial resolution of the PET component compared to the CT component. And the acquisition position in most of the PET-CT scans are that the hands are placed above, which is a standard protocol. So if you are treating a patient in the hands down, then doing a co-registration kind of becomes difficult. And also there is a time delay between the PET and the CT part. So the PET scan is done first and the CT scan is done later, and then they both are co-registered. So this itself leads to certain uncertainty, especially if there is some mismatch. So these are the factors which you need to kind of keep at the back of your mind. So, but PET-CT definitely helps in many cases. For example, in this patient, there is a soft tissue mass involving the chest wall. You are unable to delineate where the tumor starts and ends, but PET-CT kind of helps you to differentiate the normal tissue, the normal paravertebral muscles, and the tumor. Yeah. Similarly, here you're able to delineate quite well the tumor with the use of PET-CT. But the most important use of PET-CT is in patients who have lung collapse. So when there is lung collapse, the CT scan just does not show where the tumor starts and where it ends, which is the collapsed lung and where the tumor is. So PET-CT helps you very well in delineating this. Again, a case in point. So this is a patient who has upper lung collapse. We are unable to make out where the tumor is, but the PET-CT would help you in this regard. But when you have tumors close to the mediastinum and the heart, again, there is some physiological uptake in the lung and the mediastinum, physiological uptake in the heart and the mediastinum pool. So there you might find it a little difficult to control. So this is one of the pitfalls of using PET-CT for co-registration. PET for your contouring. It is also important to remember what kind of SUV, standardized uptake value, that you're using, because it is set by the nuclear medicine physician. So it is useful to actually have a discussion with them to ascertain what kind of SUV that they have set. This is generally set at 2 to 3, or sometimes it is set as a certain percentage of the SUV max. But as I said, it is always good to have a discussion with them so that you're not blindly just following what is seen as a bright spot on the CT scan. So let's now move on to how do we draw the GTV lymph node. This again is something that you do in discussion with your radiologist and nuclear medicine colleagues. Radiology, because sometimes there might be some confusion between whether the lymph node is actually infective or diseased. So based on certain features, whether the architecture of the lymph node is maintained or not, whether there is a fatty hilum is present or not, or whether there is some extranodal extension, you could have a differentiation just radiologically whether the lymph node is involved or not. Similarly, when you have SUV as high as the primary in the lymph node, then you're fairly sure that the lymph node is involved. So this discussion again would help you contour only the diseased lymph node and not infected node, because many times we do see patients with previous history of tuberculosis or some certain other infective disease, which can lead to enlarged lymph nodes. So to avoid this confusion, it is always good to have this discussion. Sometimes when there is absolute dilemma and it is impossible to differentiate, then you could go for an endoscopic endobronchial ultrasound guided FNAC or a EUS guided FNAC to find out whether a lymph node is involved or not. This is very important, especially in patients who have a contralateral hilar lymph node or contralateral mediastinal lymph node, because it makes a huge difference if you have to include a contralateral node, because that would increase your the target volume that you want to radiate. So this is just a flow chart to tell you the incremental value of PET-CT scan and EBUS whenever that is done, and to tell you how much percentage you might be sure that this lymph node is actually diseased and not infected. So once you're done with drawing your GTV primary and the GTV lymph node, the next step is to draw the CTV, which is adding the subclinical extent to the cross disease. So what we generally do is based on the Gerard's seminal paper, which was published in 2000, where they found that when you give an 8 mm margin for adenocarcinomas and if you give a 6 mm margin for squamous cell carcinomas, 95% of the microscopic extent is covered. But you need to remember that this paper was actually based on a surgical series where patients had undergone surgery and then the subclinical extent was ascertained. But the kind of disease that we treat are mostly advanced than an early stage. So there your microscopic extent might be slightly larger. So again, this is something that you will do with experience. At our institution, we kind of have ascertained based on our patterns of failure that a 7 mm to 8 mm margin is fairly good enough for your CTV primary expansion. For your CTV lymph node, there are two ways to go about it. You can just draw the lymph node as a GTV, like how we did for your primary. You draw the GTV node and give an expansion by either 5 to 8 mm to make your CTV lymph node. Or using the ISLC map, you could draw the entire lymph nodal station. So this again, both of these are acceptable practices. We tend to do this rather than this. But when you have multi-station lymph nodal involvement, you would rather include the entire lymph nodal station. Again, we don't do elective nodal radiation, but we do only the involved field radiation. We only include the lymph nodal station or the lymph node that has been involved and not the entire medicine, like how people used to do in the earlier times. Because based on our local failure patterns and possibly some incidental dose to the other part of medicine, that is good enough to cover disease if at all there is anything. So you don't have to go additionally include all those lymph node stations. The next part is to make sure that you have a standard nomenclature and standardization of the way that you color code them. Again, this it varies in different institutions, but it is important to have your own standard way of doing this. So this is what we do at our institution. This is how we name our organs. This is how we name our target organs. This is how we color them. So this sometimes it is important because you need to have a uniform way because you kind of get accustomed to seeing these contouring names and colors over a period of time. So now moving on to our planning part. We have done the contouring, you've done the simulation, you've done the contouring. Now how do we go about planning? As I mentioned earlier, we don't do much of two-dimensional or three-dimensional, especially for radical patients, CY. But when you're doing two-dimensional, how we used to do earlier times is that we generally used APPA fields with some blocks or MLCs when there was some facility to do that. But most of the times we were doing two-dimensional based planning only for patients for palliative treatment. This too, especially for patients who present with small crisis or patients who have cord compression because of the primary, or more commonly when there is central obstruction and the tracheobronchial leading to distal collapse. So you want to start your treatment quickly, and that is why you used to do just APP fields, and that serve the purpose most of the times. But the downside of that is that whenever you're doing two-dimensional radiation planning, so this is how it typically look like a PPA or portal. So this is where your primary is, but you still include the entire lymph node station. So this means that much of the mediastinum and much of the normal lung gets radiated, which can lead to increased toxicity. So this is a field arrangement for a simple hilar tumor, and this is for lower lobe tumor. As you can see here, the entire mediastinum is radiated and a significant amount of lung is radiated. So although you might be adding some blocks or shields or MCs for that matter, it would still lead to significant doses to the normal structures and increased toxicity. So when we moved to three-dimensional, when we had CT scan-based plannings, there was some improvement in reducing the normal tissue doses, but still not as good as what we do currently. This is because even for locally advanced disease, you cannot just do a simple single-phase planning. Typically, you use a APPA as your initial phase, and then you use a conformal second phase planning. This is because if you just had a simple tumor like this, then you could get away by just doing a three-field arrangement. But most of the time in lung tumor, you have complex volumes because you have the primary and then you have hilar lymph nodes and the mediastinal lymph nodes, which means that putting a 3 or a 4 field 3D-CRT plan would still lead to some difficulty in covering the tumor in entirety without increasing the dose to the heart and the lungs. So that is where IMRT comes in. In the last decade and a half, we have been able to make huge strides in our radiotherapy planning, and we have reduced our toxicity because of radiation thanks to our improvements in the delivery techniques. So when we use IMRT, again, there are a few caveats that you need to remember. We typically use coplanar beams. We don't use non-coplanar beams. We reserve these non-coplanar beams for certain patients in whom we are doing SBRT, but even in SBRT, we do coplanar. But we make sure that we are not using non-opposing fields, because whenever you're using opposing field, that increase the dose to the normal tissue, the hot spots in the lung tube. It's preferable to use non-opposing fields. And you should be careful where you're placing isocenter, because the planning purpose is if you place it in a place where there is change in contour abruptly, that would lead to uncertainty and possibly geographical miss also. So the volumetric modulated arc therapy it differs from IMRT in the way that what we used to do earlier with IMRT was using fixed field beams, or the step and shoot as it was called. So here you could have multiple beam arrangements for this typical 7-field arrangement when you have a accelerated disease. or when you have contralateral disease, you have much more complex field arrangements. This would still lead to significant low dose spillage to both the lungs, although your high dose might be conformal to the target, but the low dose spillage is much better. So with the advent of BMAT planning, what we are able to do is using these treatment arcs, what we are able to do is control the spillage to a certain extent. Again, there are multiple ways of going about it. We use a hemi-arc for a patient who has a peripheral disease, and for patients who have mediastinal disease and possibly contralateral lymph node disease, we might be using a full arc also. But when we are using full arc, again, we tend to use something called as a sector avoidance. This is again very important in patients in whom you want to reduce the lung doses, or if you have the shoulder or the arm in the way, then by using a sector avoidance, the lateral direction, you could control the dose to the heart and the lungs to a certain extent. This is just a pictorial representation of how IMRT and the BMAT dose distribution differs. As you can appreciate it here, the low dose spillage with IMRT is much more than what you can achieve with BMAT. So coming to the dose, what dose we use is typically 60 gray in 30 fractions, is done once daily, 5 days a week, concurrently with either weekly or 3-weekly chemotherapy. There are certain altered fractionation schedules that can be done. So you can do both hypo and hypofractionation. Hypofractionation we use for patients who have smallish tumors and patients who require quick relief from their symptoms. And this we typically tend to use in patients who have tumors, squamous cell carcinomas, which invade the chest wall in the brachial plexus region. So there we use 50 gray in 20 fractions, which is 2.5 gray per fraction, or 55 gray in 20 fractions, which is 2.75 gray per fraction. So the advantage there is that you're finishing the treatment within 4 weeks. And you could deliver this hypofractionation with concurrent chemotherapy as long as your volumes are not too large, or your esophagus is not part of the PTV. If esophagus is also part of the PTV, then the chance of esophagitis is much higher, which can be significant morbidity. Hypofractionation we use for limited stage small cell lung cancer, and that is more theoretical because practically it is impossible at our setup to deliver 2 fractions for a single patient. But if you don't have a very busy setup, you could do hypofractionation with a similar field arrangements. Coming to the matter of doses, we've been using 60 gray for almost now 2-3 decades. This is because we established 60 gray was better than 40 or 50 gray way back in 1975 based on RTOG trial. But since then, multiple studies have actually shown that the higher dose delivery would lead to increased local control and possibly increased survival. So to see whether this increased dose actually is translating to survival benefit, this seminal RTOG study was conducted, RTOG 617, which randomized patients between 60 gray versus 74 gray. And unfortunately, it showed that patients who received 74 gray actually did not fare well. They did worse than the patients who received 60 gray. So without going into the details of this paper, what we did learn from these, what we did learn from this study is that the factors that were predictive of overall survival was the doses to the heart and the PTV dose, which possibly led to certain increased unrecognized toxicity in patients with the higher dose. So we also saw that even if you do 74 gray, patients still continue to have a higher rate of local recurrence, and as I mentioned, there were a lot of unreported treatment-related deaths, possibly cardiopulmonary in nature, and also 74 gray given over 8 weeks possibly led to worse outcome in this arm. So what we learned from this study is that we have probably done dose escalation in the wrong way, not in the most appropriate way, and possibly we need to think a little smart about it rather than just do dose escalation as we've been doing. What we also learned from this paper, this important paper, is that the importance of doing IMRT and the advantage of IMRT over 3D, because there were patients who did receive both, who did receive 3D and the patient said IMRT, when they compared between these two patients, what they did find is that the rate of pneumonitis was significantly lesser with the use of IMRT as compared to TDC. They almost have 20 patients, 8% of patients getting radiation pneumonitis is grade 3 or more, only 4% patients having grade 3 or more radiation pneumonitis with IMRT. This is despite the fact that most of the patients with IMRT had a higher PTV than compared to PTV in TDC patients. So this is the advantage of using IMRT, that you're able to reduce the costs. So this is how the different dose constraints that are prescribed in this, how we evaluate the plan once it is being made. You tend to see whether your 95% of your dose is actually covering 95% of your PTB volume. That is at least a minimum. If you're able to achieve something more than that, that is fine. But this is a minimum that you need. So 95% to 94% is a minimum that you need. Apart from the PTV, you also need to look at the various doses to the organs. At this spinal cord, you wouldn't want anything more than 50 gray. Lung, there are various ways of doing this. So the most commonly seen parameters of lung dosimetry is that you look at the mean dose and you make sure that it's less than 20 gray. And you also look at the volume of lung receiving 20 gray, and that has to be less than at least 20%. So this is lung minus PTV, and this is what we do at our institution. So if you look at the RTOG studies, what they had done is that they were evaluating lung minus GTV or lung minus CTV. So they would allow a V20 of up to 35%. Since we use lung minus PTV, we kind of keep a little more tighter, and we make sure that the V20 volume receiving 20 gray is not more than 20%. This is most of the time achieved, but when you have large volumes, you might have to make certain adjustments, some compromises you have to make. In some patients, you might even have to take a consent for high risk of radiation pneumonitis later on in their life. For heart, we again use these constraints. We also look at, in addition to the V60, 45, we also look at the V40, and we make sure the V40 is not, the volume receiving 40 gray is not more than 30%, and also the volume receiving 30 gray is not more than 40%. So those are the important dosimetric constraints for heart. Esophagus, you have to ensure that there is no hotspot sitting on the esophagus, because esophagitis can seriously compromise patients' tolerability of the therapy. If you are treating a superior sulcus pancreas tumor, you need to make sure that your hotspots are again not sitting on the brachial plexus. So as I mentioned earlier, dose escalation by using the uniform dose escalation has not worked. So there are various ways of doing. People are looking at various ways of doing it. One way of doing it is by using something called as isotoxic dose escalation, wherein you keep the dose to the normal structures as at a threshold, and you increase the dose to the target without increasing the dose to the normal tissues. You increase the dose to the target until you hit that threshold, and once that crosses, you stop the dose. So with that, this is something that has been tested in phase 2 by multiple institutions and has been shown to be effective. Whether it is really useful in a clinical setting has not been tested in a phase 3 setting yet. The other way of doing a dose escalation is by just doing boost to a subvolume within the GTV. So this could be based on a PET scan, or you could do a SBRT boost after you finish conventional 60 gray also. So there are a lot of evidence for all these ways of doing it. But again, these are single institutional studies. Some of them are phase 3 randomized controlled trials. With proton therapy, we know that our dose conformity is better. The normal tissue receives lesser dose. So if the facilities are available, definitely we could do, at least in patients in home, the doses to the lungs are pretty high with conventional photon therapy. As I was mentioning about altered fractionation, hypofractionation using the chart has been tested in multiple randomized controlled trials earlier in the early 2000s, and that is again something that can be done, but for practical purpose, it is impossible to do it in most of the institutes. Now, with the advent of immunotherapy, it is all we know that adding adjuvant development to patients improves significantly not only their progression-free survival but also their overall survival. So we are going to have patients who are going to live longer. As you see here in the early 1980s, based on the RTG 7301, which established 60 gray as the standard treatment. From there to the Pacific, we have made significant gains in terms of improving patients' life. So at the same time, we have to be also responsible because we're going to have patients surviving for longer. We don't want them to suffer with unnecessary radiation-induced complications. So all the more reason to concentrate more on the doses to the lung, to the heart, and also importantly in the era of immunotherapy, concentrate also on the mediastinal pool of blood, because it has been shown that once we radiate the mediastinum, where there are great vessels, a significant blood gets radiated, which can lead to drop in drop in lymphocytes, which is important for the immunity. So patients who have higher dose to the mediastinum pool actually fare worse, especially if they're going to receive immunotherapy later on. So this is again something that we need to keep at the back of the mind. So the other part of radiotherapy planning is to ensure that the proper dosimetry is being done, make sure that we're using appropriate dose calculation algorithm and the calculation grid size. I mentioned briefly about the heterogeneity earlier. So as you know, the lung is filled with air, so which is significantly less dense than the other part of the body. So if you don't use a heterogeneity correction, what might happen is that you might actually you might be thinking that you are delivering a high dose, but you're actually underdosing the target. So this is actually seen in this RTOG 617 trial, where they thought where actually older algorithms were used, and when they actually used modern algorithms, they saw that instead of 60 gray being delivered, actually 54 gray was what was the entire target getting. So this heterogeneity correction is something very important. We have to make sure that the physicist knows about it. That is implemented. So most of the modern workstation, which has the recent algorithms, do take into account the heterogeneity correction. So this is just an example of a patient who was treated at our institution with a large upper lobe and the middle lobe tumor with mediastinal lymph nodes, subcarinal lymph nodes. So this is the field arrangement that we did in this patient. This is the 95% isodose, nicely covering the target. But when you look at, so this is the 30 gray volume, which again is quite limited to the same side lung and not to the, it's not spilling to the opposite side lung. But when you look at the B5, the volume between 5 gray, you can see that significant part of the contralateral lung is getting 5 gray. This, despite the fact that you used a hemiarch, the exit, since it goes outside through the opposite lung, you have some low dose spillage in the contralateral lung. But still with BMAT, we are able to kind of reduce this as compared to IMRT. So this is how the deviation of this patient looked. As you can see, so this is the yellow thing is the lung. The B20 is much less. It's less than 20%, and the mean lung dose is also less than about 12-13 in this patient. And since the patient had a right-sided tumor, the heart could be spared entirely. So the heart dose is significantly less in this patient. There's another patient who has slightly larger tumor in the left upper lobe and also mediastinal lymph nodes. So we had to use a slightly extended hemiarch here. So here again, this is the 95% isodose. This is the 20 gray volume, and this is the 5 gray volume. Again, we are able to spare much of the opposite side lung, despite the tumor crossing the midline. So again, here slightly the V20 is still less than 20%. So this lung is again lung minus PTV, and your V5 is just about 60%, which is what we try to achieve. And your B10 gray is less than 40%, which is again one of our dose soft constraint. The hard dose is slightly higher than the earlier patient because this patient has a left-sided disease, but still your B30 is less than 40%, B40 is less than 30%, and your mean hard dose also would be less than 26-27 gray in this patient, which is what we're trying to achieve in most of these patients. So once you're done with the planning, it's important to do your treatment delivery properly. Various matching techniques that can be done. I'm not going to go much into it, but this is what we do. You do a bony landmark registration first, and then you do the soft tissue registration. It's called as a dual registration. Then you make sure that the PTV is within your tumor. So sometimes PTV is within your PTV. Sometimes when you have fiducials or if you have certain landmarks within the CBCT that you're able to identify. You could use those. For example, you could use this pulmonary vessel to match your CBCT, or if you have placed some fiducials, especially in patients who are being planned for SBRT, you could match with those fiducials also. The other important thing that I want to touch upon before I conclude is the importance of adaptive radiotherapy, because in lung tumor radiation, many of the times you do see certain changes, some changes which could lead to increase in the target volume, sometimes it can lead to decrease in the target volumes. For example, when the patient develops lung collapse, that would lead to significant change in the tumor volume, both in terms of volume and also in the position. So again, that can lead to serious geographical miss. So that is something that you need to monitor for. Sometimes patients can develop pleural effusion, or existing pleural effusion can resolve. So that is again something that you need to remember. Many times you can have tumors which are responding to your treatment. Again, you need to keep this in mind and adapt your treatment as and when needed. There are various studies which are looked at the frequency of doing adaptive radiation in lung cancer patients. The most commonly done is that if you do once midway to the treatment, that should be good enough. In patients who are receiving post radiation post MACT, again, there's a lot of uncertainty as to what you want to include in your CTV. What we generally do is that we include the pre-chemotherapy extent and the post-chemotherapy volume is what we use in these patients, because most of the patients fail at the site of gross disease rather than anywhere else. So to summarize, this is my last slide. So the practical consideration that you need to remember when you're doing radiotherapy planning in lung cancer is that you need to mobilize these patients appropriately. You need to choose an optimal motion management technique, so whichever is available at your institution. While you are doing your contouring, pay attention to the way you're doing your contouring. Are you contouring only using MIP, or you are using different phases? And when you're using PET-CT for your co-registration, try to do the PET-CT co-registration as much as possible, but again, keep all those caveats that we discussed earlier in the back of your mind. And when you're doing the planning, it is always better that you use VMAT, because it has been shown to be better than a 3D CRT in terms of sparing doses to the normal tissue. And also, we discussed about the dose, and the fractionations, and the beam arrangements that are ideally done for these patients. While you're doing a plan evaluation, the dose constraints that we discussed are something that you need to keep a close watch on. When you're delivering your treatment, make sure that you're using the appropriate online strategies that are available at our institution. And also, importantly, watch out for the need for adaptive replan. So with that, I'll stop my presentation, and I'll be happy to take any questions if there are any. And again, thank the organizers for inviting me to give this lecture. Thank you very much.
Thank you, Naveen sir, for that comprehensive talk. I would like to ask all of the participants, if you have any doubts, post your doubts in chat box. Dr. Naveen sir is here to answer your doubts. And Dr. Naveen sir, are you here? Dr. Naveen sir?
Yeah, I'm here.
Sir, would you like to add onto anything to your?
Can you come again? I lost you there.
Sorry, sir. Can you add? Would you like to add anything else to your current lecture? We don't have any questions right now.
Okay, so I'll hang on. If there are any questions that comes in the chat box, I'll be happy to answer them.
Okay, so since we don't have any other questions at the current moment, so we would like to move on to the next lecture, and I would like to call upon Dr. Moses Arun sir. He's current assistant consultant, Department of Radiation Oncology, Tata Medical Center, Kolkata, and he will be talking about motion management SDR. Sir, you can start your.
Right. Is my slides visible?
Yes, sir, they are visible.
Okay, thank you. Thank you, everyone. Good session so far, and I won't take too much of time. I think some of the slides were already explained by Dr. Naveen, and it will be a revision. So I'll just try to skip through those slides as soon as possible. And at the outset, I'll also like to thank the organizers for inviting me to talk on this meeting. So the mandate given to me is to talk about motion managements, particularly in terms of early stage lung cancers undergoing SBRT. So when we talk about radiotherapy, Dr. Naveen mentioned about different concerns that we have in terms of interfraction and intrafraction motion. But when it comes to respiratory motion, it is most commonly the intrafraction motion that we are worried about. And in addition to respiratory motion, we have other causes of intrafraction motion as well, cardiac, gastrointestinal, and skeletal muscular movements. In the upper thoracic and the upper abdominal regions, at least the gastrointestinal system movement is not going to make much of an impact in terms of intrafraction motion. Cardiac is something that we cannot do much about, so we'll just have to take it as it is. And skeletal muscular movements we take care of by doing immobilization procedures to the extent that is possible. So when we talk about lung SBRT, because there are going to be long treatments, we have to think of immobilization procedures which are comfortable for patients to take these long procedures. There's no clear evidence that any one immobilization method is superior to another, or even if strict immobilization methods are needed for lung SBRT as well, as long as you have robust imaging and imaging-based image guidance algorithms available to correct any errors that can come up. So this is a video that Dr. Naveen as well showed. I mean, respiration as such looks like that is which is a simple movement. We are most often not aware that we are breathing, and although we do have, it's most often a involuntary action, but we do have some voluntary control over it to an extent, at least, where we can hold our breath or control our breathing pattern. Patients can be manipulated to breathe in a particular pattern and hold breathing motion as well. And these are some of the techniques that we use for managing respiratory motion. We'll see that a little in detail as we go on. Just a quick recap about how respiratory motion happens in the body. Diaphragm, this thin paper-like muscle, which separates the abdominal cavity and the thoracic cavity, is the main muscle of respiration. What happens is when you inhale, the diaphragm muscles are the ones which are contracting, creating a negative intrathoracic pressure, which into which the lungs expand and sucks in air from outside. And then when you inhale out, exhale out, the diaphragm again relaxes and pushes up the lung, forcing the lung to contract and push out the air outside into the atmosphere. So the volume of the inhalatory lung and the exhalatory lung is a little different, and that is what leads to hysteresis. Again, that was also mentioned in the earlier talk. We will see about that later in the talk as well. But diaphragm is not the only muscle that contributes to respiratory motion. There are plenty of other muscles like the intercostals and the other accessory muscles which contribute to respiratory motion as well. So diaphragm being situated where it is, separating the thoracic cavity and the abdominal cavity, all the organs situated above and below the diaphragm are affected by respiratory motion. But for this talk, we will restrict ourselves to lung tumor motion. So what are the problems that we face with respiratory motion when it comes to radiotherapy? So radiotherapy is a multi-step process. We acquire image, then we do the treatment planning, and then we deliver treatments either in a single fraction or in use very often in a multi-sitting fractionated treatment. And in every phase of this treatment pattern, we can face problems with regards to respiratory motion. And that is what we are going to look at in the next few slides. So with regards to image acquisition, when we usually acquire a conventional CT imaging, which is not respiratory correlated, we can face a lot of uncertainties in identifying the correct position or the volume of the tumor. And these, if we do not take into account, can lead to incorrect positional and volumetric information, and that can in turn lead to inaccuracies with the dose calculation that we do based on those non-respiratory correlated images. And these are some of the artifacts that we see with the non-respiratory correlated CT, very often seen in thoracic CT scans and upper abdominal CT scans, where the organs and the tumor as such are moving a lot because of the movement of the diaphragm. And that these artifacts happen mainly because the reconstruction algorithms assume that for each slice of image that is taken, the anatomy of the image structure is invariant, but in reality it is not, and that is what leads to these sort of motion artifacts. And on the right, you can see a respiratory gated CT scan, which is taken at the exhale position, and you can see that these motion artifacts are eliminated to a large extent. The problems that we face in terms of treatment planning is when we do not have a respiratory correlated CT, we have to account for the motion that may be there in the tumor by way of giving additional margins to cover for the motion of the tumor and the organ itself, and also the margins in addition needed for setup errors that happen during treatment. And these margins are usually calculated either based on a crude method of estimating the respiratory motion, or we use the population-based margins that we have. The problems with using such margins are we can either cover the volume of the tumor less and lead to compromise in tumor coverage, or you may end up treating a larger volume wherein the tumor is situated near a very critical organ. You end up giving more toxicity. These are the problems that we can face with treatment planning. But what about treatment delivery? Usually our treatment beams are static, and when a tumor is moving in relation to these static beams, there is going to be averaging on or blurring at the edge of the tumor as the tumor moves. And this sort of blurring is more near the beam edges, and this can be very unacceptable in terms in the situation of SBRT or IMRT, where we are deliberately keeping the margins tighter, and also our dose fall off beyond these volumes are kept very steep deliberately. So we've understood that there is a problem of respiratory motion in the thoracic cavity, but before we go about managing the respiratory motion, we need to go and measure the kind of respiratory motion that we have, and get an idea of the immensity of the problem. Various people have done a lot of studies on the extent of respiratory motion that happens in the thoracic cavity. They have either tracked the tumor as it is visible, or they have tracked the host organ, or they have placed fiducial markers in or near the tumor, or they have used the movement of the surrogate markers, surrogate organs to estimate the extent of respiratory motion. So we look at a few examples of how people have estimated it. So you can get an estimate using a fluoroscopy. If you get it only in a single angle, in a single plane, then you get a good estimate of the trajectory of the organ motion or the tumor motion. And also you get an estimate of the relationship in the motion of the tumor itself with the related structures that are nearby. But the information that you lack in a single 2D image would be that you don't get information about rotation, out of plane motion, or deformation. But if you add another imaging of the same type at a different angle, then you can use an algorithm to reconstruct it and get a 3D fluoroscopic imaging as well, which is in fact what is done in angiography and also in CyberKnife as well. Also, you can do CT scans at the extremes of the respiratory cycle, that you can ask the patient to hold breath at inhale and at the exhale position, and get the full range of the tumor motion in the 3 dimensions. But what will be lacking is the actual path through which the tumor is traveling, and also the relative positions of the tumor and the nearby organs when we are just imaging at 2 different positions alone. Finally, 4D CT scans is where you are actually correlating each of the image to the actual respiratory and the position of the respiratory cycle at which the image was taken. So you get a full range of the tumor motion throughout the respiratory cycle in relation to all the other organs. But because the tumor is moving, there is going to be some blurring, and that leads to some reduced spatial resolution. Sorry. People have measured the respiratory motion in the abdomen and the thorax. When you look at the respiratory motion in the abdominal cavity, it is mainly happening in the superior inferior direction. That's the craniocaudal direction. But there is minimal impact of respiratory motion in the anterior-posterior or in the lateral directions. But when it comes to the lung, you can see that there is quite a lot of variation in each of the axes, and there is no clear correlation as to with regards to either the position of the tumor, the size of the tumor, and none of these could be clearly correlated to get an estimate of the respiratory motion. What this in fact shows us is that the respiratory motion needs to be individually measured and is correlated for each and every single patient. Again, this cartoon also was shown in the earlier talk. Again, it shows that it has to be individually measured for each and every patient. And also this also showed about hysteresis, which hysteresis meaning because the volume of the lung during exhalation and inhalation is completely different, the tumor takes a different trajectory when it moves up and down. The trajectories could be separated as low as by 1 millimeter or as large as even 5 millimeters. So in inhalatory phase and then the exhalatory phase, the tumors are occupying different positions within the same lung. So all these are important things for us to know when we are trying to manage respiratory motion. So we've understood that there is a problem, and we have ended up measuring respiratory motion as well. But just because we know there is a problem and we are able to measure it, should we always manage it is the question. Different groups have come up with different solutions on when we should manage it. The estimate is that if you are able to reduce the expansion of area that is required for covering a moving tumor by anything to less than 5 millimeters in any direction, then you should possibly opt for a respiratory motion management, provided that you have a solution that is available in your department, and the patient, that specific patient is able to tolerate that specific procedure. This is, I believe, from a Japanese group. They took a different approach. So they estimated the total vector of displacement of the tumor, and estimated that if it is less than 1 centimeter, it may not be worthwhile opting for a motion management method, and it may not be cost effective. But anything more than 1 centimeter, you should definitely consider a motion management method. So we coming finally to managing respiratory motion as such. They can be broadly classified under these 5 heads. So first is the motion encompassing method. The second and the third are both gated. The pure respiratory gating technique and the breath hold techniques. And the next one is forced shallow breathing methods. And last, the ideal method would be the real-time tumor tracking method. So we will look at all of these in a bit in detail. So the 3 common, so the motion encompassing methods are some of the commonest methods that are used for managing respiratory motion when it comes to treating early stage lung cancers. And the 3 of the commonest methods are acquiring a slow CT scan, or otherwise called as a axial acquisition, or what I talked about, acquiring images at the end in his extremes of the respiratory cycle, or finally acquiring a 4D CT scan, which is a true respiratory correlated CT scan. Sorry. The slow CT scan method is something that is available in most CT scanners, in contrast to helical CT scan. You operate the CT scan at a much slower rate, wherein the couch moves much more slowly, and each part of the thoracic cavity is imaged multiple times as through multiple respiratory cycles. So in effect, catching a more full range of respiratory motion of the tumor within the lung. And because the tumor is moving as the images are being acquired, there is less resolution that is available in a slow CT scan. But these are not ideal images when the tumor is located nearer to the chest wall or to the mediastinum, where there will be a loss of contrast and inability to differentiate between where the tumor ends and where the normal structure starts. Next up is where you acquire CT scans at the extremes of the respiratory cycle. We have talked about it. Because the tumor is not moving, because the patient is holding breath, you get less blurring of the tumor, and you get much more resolution. But because these patients are being artificially asked to hold breath, there is always a possibility that there is large displacement than free breathing, which can, if not addressed properly, can lead to systematic errors throughout the treatment. So the dose calculation usually in this sort of CT scans will be performed in a data set, either the exhale or the inhale, which is most appropriate for the patient. Patients are usually able to hold breath more at exhale. So that is the one which is usually used for planning in these sort of treatment techniques. For both acquiring the images and for treatment delivery in motion and in an extreme CT scans, you will need something of a respiratory monitoring to verify the gated delivery or the breath hold constancy. Last method of motion encompassing is kind of considered the gold standard for motion encompassing techniques, which is the 4D CT scans. The 4D stands for the 4th dimension of the time that is being added into the 3-dimensional non-respiratory correlated images. Herein, you get an excellent compromise between the time resolution that we get with a fluoroscopy and the detailed 3D spatial information that you get with a conventional CT scan. So the information that you get from a 4D CT is that you get the full range of the tumor motion for treatment planning, and also you get the relative positions of the tumor and the other organs which are nearby in the thoracic cavity as well. Yeah, so this is what I have mentioned about already. So the images are taking up some time to load up. Yeah, so these are some of the 4D CT scans that were done in our department. You can, I mean, the motion of the tumor as such is minimal, which is what you would expect in an upper lobe tumor. But you can see that whatever minimal movement is there is picked up by the 4D CT scan, and you can appreciate the movement in relation to the mediastinal structures movement as well. So a little bit more in detail about how to go about acquiring a 4D CT scan. So when you are acquiring a 4D CT scan, you need to correlate each of the image that is taken with which particular part of the respiratory phase in which it was taken. So for correlating that, you need some external surrogate for tracing the respiratory cycle. So there are various solutions available in the market. So you can use a spirometer-based respiratory tracing. You can detect the changes in the nasal temperature during the different phases of the respiratory cycle and use that to correlate with the images that are acquired. You can use a sensor placed over the abdominal wall, which moves up and down during the respiratory cycle to correlate that with the images that are taken. Or you can use infrared motion sensors, which are kept on some part of the abdominal wall. So usually before we go ahead and do a 4D CT acquisition, we place the patient on the couch in the comfortable position and assess the breathing pattern and the rhythm of the patient before we go ahead and acquire the CT scan. And this is something that of an important step, because the radiographers and your physicists and yourself should be on the same page and be convinced that the patient is having a regular breathing pattern, which will be replicated during each sitting of the treatment as well. If this first step is not very clear, you may what we do in our department is usually we ask we coach the patients for at least 2 or 3 sittings before we take the patient on for a final 4D CT scan. If even after that, if it is not correct, then you may have to think of doing other forms of motion management rather than doing a 4D CT scans. Usually we take, as mentioned earlier as well, that from cricoid to L2 with slice thickness of 2.5 to 3 millimeter or less, you get, I mean, after all these images are taken, they are binned into temporally binned phases of the breathing cycles. And also you get other reconstructions as well from these images. We'll have a look at that later, I believe, in the talk. A little bit more in detail about the Varian RPM, which is what we use in our department. So this contraption has a simple plastic box with a few reflector dots on the plastic box, which is usually kept on the abdominal wall between midway between the xiphoid process and the umbilicus. In someone who has a scaphoid abdomen, we may have to push up the reflector box a little bit higher up so that it is as horizontal as possible. And then you have the IR camera at either the foot end of the couch or on the wall at the foot end, which emits both the infrared rays and also detects the reflection from the detector box. If someone has, someone is very thin built and the aortic pulsations are being transmitted onto the plastic box, then you may have to keep the plastic box off center as well. If you are thinking of using a technique wherein you want respiratory monitoring constancy, monitoring during treatment delivery as well, then you will need to keep this box during treatment also. So then it may be a good idea to mark out the edges of the reflector box with tattoos and also measure it in relation to a nearby bony anatomy and mark that down onto the patient file for replication throughout the treatment. So this is the kind of trace that you will get on the RPM software interface. And this is a video to show how the images are tagged and sorted. So as the images are acquired in different phases, depending on the RPM signal that they are getting, they will get tagged into different phases of the cycle, and they will be bin together. So here as representation, it is shown as 4 bins, but in reality we get 4 bins, and also you get other projections as well. So the maximum intensity projection is created by putting the maximum CT number or the Hounsfield units for each voxel in the entire set, or for each voxel you put in the average intensity, then you get the average intensity projection. So the advantage of MIP, if you look at it, the way the MIP projection is constructed is similar to slow scanning acquiring. So the difference, the advantage is that because the MIP is a reconstruction, you get less blurring that is caused by motion. So the resolution is a little bit better compared to slow scanning. But 4DCT is not without its artifacts. So you can see that when the tumor is moving between the two extremes of the respiratory cycle, you can see that it is difficult to localize. So you get less resolution if you are trying to localize the tumor between the two extremes of the respiratory cycle, whereas at the extremes, it is much more precise and is more similar to a conventional CT scan. Even with the 4D CT scan, we just mentioned that it is possible to get artifacts, and some of these artifacts could be because a patient coughed or moved during the acquisition of the 4D CT. So before you take the patient off the couch, you get all these checked, all the reconstructions checked, and see if any of these artifacts are actually in the position where your tumor is. If that is the case, then you will have to take a call on whether you want to go ahead with another 4D CT. But keep in mind that these are images. I mean, these are techniques which deliver a lot more radiation as compared to conventional CT scan. Or if you want to opt for a different kind of motion management method. I think I'll just skip some of these slides for want of time, or just maybe run through it. So advantages are you get the full range of tumor motion and also the organ motion with a minimum of motion artifacts. You can use the average intensity phase for planning and dosimetry calculations, which are much more representative of the geometry that will be there during treatment delivery. So in effect, you get less deviation from the actual dose that will be delivered during planning. It is, but the limitations are that even during the acquisition of the CT or in between the acquisition of the CT and the treatment delivery, the respiratory patterns can vary, and that will impact the kind of optimal coverage that you're able to give. And the radiation dose from these sort of techniques are much higher than a conventional CT scan. One of the other limitation could be that for a lower lobe tumor, if you acquire a full day CT scan, and if you are thinking of doing an encompassing technique, when you do it on a MIP image, you can see that it goes onto the liver, because it is difficult for you to differentiate between where the tumor is ending and the liver is starting. When it comes to gated technique, you are gate is just a part of the or a portion of the breathing cycle, wherein you decide on that portion depending on where you are feeling that the motion of the tumor is much less. So you treat or image only during a portion of the breathing cycle. So as you can imagine, because you are treating only during a part of the breathing cycle, these sort of techniques are going to be much more longer duration than the conventional technique. So you can, there are different ways of classifying the gating. You can do a prospective gating, wherein you decide the gate even before the image or the treatment is delivered, or you get the phase-based gating, wherein you set the gate based on the preset phase window. Duty cycle is the efficiency of the time spent by the signal within this gate to the overall treatment time. And these are things that you need to keep in mind when you think of using gated delivery. So this is just a cartoon to show how you treat only during the part of the breathing cycle during a gated delivery. And when it comes to breath hold techniques, you can herein you ask the patient to hold the breath for some time at a particular position. You need a respiratory monitoring for verifying the constancy before you are able to deliver this treatment. You can also, you can do this with spirometer-based systems, vary an RPM, or you have the active breath-controlled techniques wherein a spirometer kind of contraption is attached, and the patient is we are able to hold the patient's breath at a pre-specified volume. Patient is able to monitor the amount of time that is left behind for that particular breath hold. And in that way, you are able to deliver a treatment when the patient has held the breath for some time during their respiratory cycle. The next method is when you are able to reduce the excursion of the diaphragm by putting pressure on the abdominal wall. This is an example where the stereotactic body frame with that attached plate is pressing up on the abdominal wall and thereby reducing the diaphragmatic movement, and thereby forcing the breathing pattern to be shallow and reducing the amount of tumor motion that happens. So this is an example of how well you are able to minimize the amount of tumor motion in a lower lobe lung tumor. Real-time tumor tracking is where you either use the linear accelerator attached to a robot, or by moving the couch to the position of the tumor. An ideal real-time tracking should be able to predict where the tumor is going to be in the next moment, and also adapt the dosimetry as well in terms of delivery. These are sort of some of the dose prescriptions that we use in our department for early stage lung cancers. This is the usual risk-adapted approach. For a peripheral lung tumor, we go with a 3-fraction treatment, and anything which is more central, we go with an 8-fraction. Anything near the chest wall, then we go with a 5-fraction treatment. We treat on alternate days with at least 40 hours gap between them, and we make sure that the treatment gets over within 3 weeks. There are different dose constraints that are available in literature. We follow the UK Saber Consortium guidelines. You can choose any one of the guidelines and just stick to that. As I mentioned earlier, immobilization is something that is important for any radiotherapy treatment, but image guidance is something that we rely on more for making sure that the treatment is more accurate. And when it comes to image guidance in lung SBRT, some guidelines definitely recommend day 0, wherein you check and make sure that the treatment that you have got ready for that patient is deliverable. A volumetric imaging to confirm patient position prior to treatment is definitely recommended, and that has been found to be superior to KV matching alone. If you have the facility to do a 4D CBCT, at least on the day 0 and on day 1, it should be considered if it is available for online matching more so. If you can incorporate it, it will be very good if you can incorporate it into your imaging guidance as well. There are baseline shifts that can happen if it is happening in relation to the bony anatomy. Maybe it is a setup error. You can reposition and see whether that works. But if it is a shift that it is happening between soft tissues, then that is something that you cannot correct by repositioning. You need to go back and re-image. I think I skipped one thing over here. Yeah, so intra-fraction CBCTs and post-fraction CBCTs are something that you need to consider as well. Intra-fraction CBCTs have also been shown to necessitate shifts in nearly 1/4 of the patients. And a post-fraction CBCT is something that you can use to see whether the treatment for that day has gone well, and if there is something that has been wrong at the end of the treatment, see whether that can be set right before the next fraction. So this is a summary of motion management for lung tumors. It needs to be individually assessed and managed. Multiple methods are available. Any of the option is better than none of the option. 4DCT is at least the current standard for motion encompassing technique. And as you can see, all of these techniques are very resource intensive. So you definitely need to have proper commissioning and continuous auditing of the process to make sure that everything is going as per your plan. With that, I come to the end of my talk. Thank you.
Thank you so much, sir, for that detailed talk. So we had two questions. First one was by Dr. Dandapat, and Dr. Naveen sir has already answered his question. So his question was that post-NSCT case, can we consider the pre-NSCT nodal GTV volume and the post-NSCT tumor GTV volume during contouring? Sir has answered that yes, you can use both pre-chemo extent of the nodal and primary disease along with the post-chemo volume. Hope that answers your question, Dr. Dandapat. Next question was Dr. Abhay, that also directed to Dr. Naveen sir, and he has already answered. So his question was, in 2D planning, what should be the field borders with respect to 2D field and 3D field technique? So Dr. Sir has answered that for palliative setting, a 1 centimeter margin, the gross disease would suffice, and in radical setting, with 3D CRT, the usual CTU expansions and appropriate margin for geometric penumbral should be used. So I hope that answers your question, Dr. Abhay. Next question is by Dr. Abhay, who I think this is direct to Dr. Modi, sir. So he has asked, how is 4D CT different from slow CT?
Yeah, so a slow CT is not a respiratory correlated CT. You are just acquiring the usual non-respiratory correlated CT scan, but in an axial manner, wherein, I mean, usual helical is just like, it's just like a helix. You are not imaging the same position of the tumor throughout the entire respiratory cycle. But in a slow CT, you are making sure that all at least multiple respiratory cycles are covered for each of the position of the tumor. But you cannot have any other respiratory cycle. But you cannot have any other projections or like a maximum intensity projection or a average intensity projection, because you do not have each of the image that is acquired tagged to a particular phase of the respiratory cycle. Whereas in a 4D CT, because you have that extra information for every CT that CT image that is acquired, it is being tagged that this has been acquired in the 10% bin of the respiratory cycle, and the next image that is acquired is in the 20%. So it gets tagged. So when you are reconstructing, you can separate out each and every image as to belonging to a particular part of the respiratory cycle. So that is basic difference between a 4D CT and a slow CT. I hope that answers the question.
Yes, sir. Next question is by Dr. Manishi. I thought a similar question. That is 4D CT really necessary for SBRT to treat single pancreas tumor or superior sulcus tumor, or can we treat with a normal scanning?
So a 4D CT is something that, I mean, usually was used for an early stage lung cancer. it is more and more being used for locally advanced lung cancers as well, but I still haven't worked out, at least in my CT machine, how to go about. I mean, I usually prefer having contrast if in a locally advanced cancer. How to correlate the both of that is something that I haven't worked out. I'm still trying to solve that. But when you talk about a pancreas tumor or a superior sulcus tumor, which is this is something that is in the upper lobe, we know for a fact that upper lobe tumors move less. And when you're talking particularly about pancreas tumor or a superior sulcus tumor, it is already invading the chest wall or the vertebra, so the mobility is even lesser. But I'm a little stumped by the question, but because SBRT is not the usual treatment for pancreas or superior sulcus tumors. There it is usually neoadjuvant chemoradiation. If someone is upfront operable, you give neoadjuvant chemoradiation and then take them up for surgery after the treatment is complete. Or if someone is deemed inoperable, you consider for either concurrent or sequential as deemed fit for that patient.
Thank you, sir. Dr. Manishi, if you are there, if you have you raised your hand as well, if you have any questions, ask. Okay. Moving on to the next question, Dr. Dibanjan has asked, sir, on day 0, should we do a dummy run on a?
Yeah, of course. You should definitely do a CBCT and confirm that the treatment the plan that you have generated is deliverable, and that includes doing a CBCT as well. If you have a 4D CBCT, that will be the best option to do it.
Thank you, sir. So Dr. Radharani Dasgupta has raised her hand. Dr. Radharani Dasgupta, you can come live if you have a question. Dr. Radharani Dasgupta. Okay. 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 Fine. So, sir, I had one question. So, while contouring the GTV primary, how strongly can we rely on PET-CT for differentiating the tumor from the surrounding areas of consolidation? And should we have any special margins in our mind for that? And because sometimes it becomes very difficult to differentiate. I mean, if it's not strongly lit, it is sometimes becomes very difficult to delineate the or to differentiate from the adjacent consolidation.
I mean, are you talking about some locally advanced disease where
Yes,
you have a consolidation as well, and then you are asking
yes,
how
sir.
is it? Yeah, I mean, it is something that is very difficult, isn't it? That's what Dr. Naveen had shown about the
Yes.
either you go with the SUV alone, or you get an arbitrary percentage like a 40% or a 42%, and take that is what is tumor, and all the rest that you are seeing is just consolidation. So it is a difficult situation, but PET is something that we have. I think Dr. Shurai also showed possibility using MRI images as well to identify consolidation and actual tumor. So yeah, it is challenging, but you learn as we go, as we keep doing these things.
Dr. Naveen sir is also here.
No, I think he has left. So he's back.
He joined again. Yes.
Dr. Naveen, you want to take that question? He had asked about using PET-CT scan to differentiate between the actual tumor and consolidation. Dr. Naveen, are you there?
Hi, Moses. I am Dipanjan here.
Yeah, Dipanjan.
Just the Bitan has asked the question. I just want to add another thing. If you can take this question also, because are you really practicing the fusion of the PET and CT, or doing the PET
no, I'm not.
yeah, because there is the phase differences in the metabolic image and the anatomic image, or what is the solution you are taking for that thing?
No, I am not. We are not fusing. We just keep it side by side on another. I mean, you have worked in TMC, so you know that we have multiple consoles available. So we just keep it side by side in another screen, and we use that to guide our contouring.
And another question with that, so whenever you are generating MIP, in that case, is there any specific thing you are practicing to differentiate the atelectasis, the nearby atelectasis or consolidation type of thing? Because whenever we are doing the MIP, we are generating the MIP, probably the resolution will be not as good as the initial image set, or you are doing anything for that?
Usually in an early stage lung cancer where you're using these sort of things, you don't usually see a lot of atelectasis. So that is usually not a problem in that setting.
Okay. Okay.
I think this brings us to the end of our today's session. I would like to ask Dr. Anjali Madam to say some concluding remarks. Ma'am, you are not audible. Ma'am, you are not audible.
Am I audible now?
Yes, ma'am. Yes, ma'am. You are audible now.
Okay. I thank all the speakers, Dr. Moses Arun Singh, and for the wonderful presentation. I think it will help all our students. I thank AROI for arranging this seminar. I thank all the organizers. And of course, I ask my students if they have the video recording to go through it, because it is very informative presentation today. So thank you all, and a very good night to you all.
Thank you, ma'am, so much. So before concluding, I would like to mention about our President of AROI West Bengal, Dr. Kiran Ahapta sir, and our Secretary of AROI West Bengal, Dr. Abhishek Basu sir. They couldn't be present here today due to some logistic issues, but without their support, this program would have not possible. So this brings us to the end of our session today. I thank you all for attending this session, and looking forward to the next module. And for any updates, you keep looking into the WhatsApp group. Thank you. Thank you all.